All righty, let's see if we can get this show on the road. We'll get everyone out of the waiting room and here into the session with us. It always takes just a moment to get everyone tuned in here. Hope you're having a fabulous day. And this week, this is a big week as we head into test day this week. I know a lot of you are testing, most of you are testing this week. Some of you are here for a preview for the January exam. And so, regardless of where you are, when you're testing, welcome, welcome. So glad to have you. So, as you get tuned in, if you wouldn't mind, just give me a quick sound and video check by just chiming in where you're tuning in from. It's always interesting to see where everyone's tuning in from for these brain dump sessions. So, uh, our goal here is to talk through as much content as we can. We're going to go for about 1 hour here. I'll try to answer as many questions as I can. I know there's lots of questions that come up. We got folks tuning in from Texas, Philippines, Indiana, Australia. Yes. Land down under Tennessee, Ohio, Boston, Massachusetts, Arkansas. Excellent. Germany, excellent. We've got lots of folks, international folks here today. Salt Lake City, let's see, best country in the world, Chicago, Texas, Milwaukee. I'm so grateful for you spending your time with me to go through content to help you on exam day. So we have quite a bit of stuff that I would like to talk about. Plus, I do want to make sure we prioritize your questions here today. So if you don't mind, over in the Q&A feature, that's a great place where you can queue up your questions for me. So if there's a topic that you'd like to discuss, kind of that one last minute thing, you're like, oh, if only we could just talk about that one more time, get it to stick, that would be fabulous. So over in the chat box, I am going to post, those of you who are part of our VIP course, as well as our crash course, you should have access to the slide deck that's already there in the shared folder. But in any case, over in the chat box, I've just pasted a link to today's notes. If you'd like to download that, you're welcome to do so. If any of you, if you wouldn't mind giving me a hand here, go ahead and copy and paste that link so that if anyone who tunes in later asks for it, you could help me out by anyway giving them the slide deck. So our goal today is to talk about content that's likely to show up on exam day. So your plan this week, if I'm not mistaken, you'll be testing either tomorrow or the next day, and the goal is to try to limit as much anxiety and worry as possible. And so our goal here is simply to talk about content that is helpful to put on your brain dump, last minute mnemonics, acronyms that can be helpful for you on test day so you can have an absolutely knock it out of the park. You've got to have a fabulous experience as you take the test. So that's our plan here for today. For those of you who don't know me, my name is Will. So I've been doing PT final exam for 12 years now. So it's like I've been studying for the exam for over a decade. And I'm not sure whether that's a good thing or a bad thing. But in any case, it lends itself well to talk through content so that you know what is likely to be tested, what's easily tested, and help go through some of that content. Just a quick shout out to those of you who are a part of our VIP class, as well as our crash courses and university cohorts. Thank you so much for your participation. Without your participation, none of this would be possible. And all of our guests and everyone who's tuning in, thank you for your efforts in becoming a fabulous PT. I know that's true for everyone here. Your goal is not just to pass a test, but your goal is to become a fabulous PT. And then that lends itself into not just your initial career, but to your patients' lives, your own life. Let me just tell you, what you're doing really matters. So let's talk about today's goal here. I want to talk about your test day experience. I want to talk about key information to put on your brain dump. We'll talk a little bit about math on the exam. That's always a fun topic of discussion. So we'll talk about a little bit of math, and then we'll conclude with any questions that you have, in addition to any other mnemonics or suggestions that you have for us today. So let's go ahead and jump in here with a couple of questions. This is from previous cohorts, and I wanted to mention because I felt like they were super pertinent. Talking about the test day itself, I'll hit on that maybe a little bit at the end as well about your precise test day strategy. I want to talk mostly about brain dumps and what you can put on your brain dump and use that to the best of your ability. So that's the goal. One of the questions I get all the time is it permissible to take a water bottle onto or into the test? And the short answer is yes. You are permitted to take with you a water bottle, a clear plastic water bottle with no writing, into the test site. You can take it right to your test seat. Now, this is a change that came about midway through last year. They started permitting water in clear plastic water bottles with no writing. You could take that into your test seat. Don't spill it on the computer. And also be cautious of how much water you drink, just because we know that, you know, I think everyone knows what we're talking about here, that if you are so diluted with water, it's difficult then to concentrate because you have to go to the bathroom. So use it as you've practiced. I guess that's the big key here there. As far as what you can bring with you to your test, you can bring what's in your brain. You can bring a good attitude, all the interesting and silly things you could say here. But what you also can bring is prepare what you'll put on that brain dump. That's what we'll talk about here. As we talk about this, just note when we talk about brain dumping, it really is nothing more than having a scratch pad. So you have a piece of paper, or on in COVID, they did pen and paper because they were disposable. But I think everyone is back to dry erase pads and dry erase markers. So basically, it's a laminated piece of paper. You walk in there, they'll hand you one of those and a dry erase marker, and you can write down and jot down things that are important, pertinent, acronyms, mnemonics. Obviously, you can't bring any outside material in. It's just what's in your mind, and then the purpose of it is to write down things that are either difficult to remember or you're worried about forgetting on test day. And it acts, there's an irony here with brain dumping, is that the more you've prepared what you'll put on it, the less you'll actually need it because you'll have prepared for it and it's locked in your brain. But there's a mental factor there where if you have something that is familiar, calming, and reassuring, it tends to lend itself to a better performance on test day. And so that's why on test day, it'll be critical to make sure that you use this to the best of your ability. What's interesting to me, this is a willism here. So, having talked to thousands of students now across the US in every practice jurisdiction, everything, I have found that some test centers permit you to start writing as soon as you get into the seat, but some test centers don't permit you to write until you actually are looking at the first question, until question one is in front of you. So check with your test center just to make sure your local policy, that everything is, you're doing things according to their precise local policy. And I guess don't get frustrated if they say, oh, no, excuse me, you can't start writing on your brain dump until you are actually in your seat, or sorry, until you're actually to question one. Some test centers, they don't care. If you're on the tutorial, it shows you how to click a mouse and advance through the questions. You get 15 minutes to perform that. So basically, you just, some test centers let you write then. So report back to me what your test center does, because it's always curious to know what the local policies are. Just also a little plug here for the NPTE podcast. Those of you who are targeting the July exam, or sorry, July, July or January or April, anything but the October. And anyone who's targeting October, you're welcome to listen for sure. Also, those of you who are going on to the next exam, be sure to check out the VIP series. So the VIP course, that's one that I personally run. We meet multiple times each week. You can have one-on-one calls with me. We have lots and lots and lots of pre-recorded material. In fact, I'm actually updating that as we speak. We're adding even more pre-recorded material, so it'll be a lot of fun. 6 practice exams currently, all of our written material. Really, it's a very robust and full study plan that I think you'll really enjoy. Plus, it's in a small group setting that gives you the opportunity to get every single one of your questions answered. So I anticipate with this large group that's here today that we won't be able to answer everyone's questions. I'll do my very best to rapid fire them. But that's one of my, maybe my most favorite part about the VIP class is that we can answer everyone's questions. We get to talk to everyone. And just a quick shout out to my VIPs who are here today, my VIPTs, that super glad to have you all here. All right, let's talk about what makes an effective brain dump. So an effective brain dump is something that's brief, has usually something that's in a mnemonic device or an acronym, something that's really easily written down and memorized. And I've got a bunch of examples coming up, but the key here is that it has to be brief. You don't want to spend time writing a 5-paragraph essay. You've got to write down things that are relevant, but that they'll prompt your memory without taking way too long to go through. So pictures are also very helpful. You can draw out little schematics and diagrams of what you're talking about. I always try to, whenever I'm talking to students as they're going through questions, I try to make them drill down to what is this question exactly telling you or asking you. And the closer you can get to that or draw it out or see it, the more likely it is you'll answer that question correctly. So let's talk through some of these things. Here, let's just dive into some examples of this. Again, some of these have varying levels of efficacy, and so you just take it for what it's worth. Or if you have an acronym that you'd like to chime in and say, hey, that really helps, then please feel free to do so. So, as an example, one of the questions I get so often is usually regarding the musculo or neuro system, but it's all about interventions. How do you find the best and most precise intervention, most direct and effective intervention for any number of conditions? And the difficult part about this is that there are so many conditions. I mean, if you look through the textbook, there's just hundreds and hundreds of special test conditions. There's a lot going on there. And so, what helped me as a new physical therapist was when I discovered that there's a pattern that shows up in most rehab protocols. And what that is the 666 rule. And so that's something I've, again, very much a willism here. But the first 6 weeks is what is called the maximum protection phase. So by maximum protection, what are we talking? This is where you're limiting range of motion, you're limiting activation of a muscle, you limit all of that, limit range of motion, usually limiting weight bearing. It is obviously quite dependent on protocol for the precise limitations of weight bearing, but this usually applies to things such as rotator cuff repairs, Achilles tendon repairs, meniscus repairs, anything where you have a soft tissue repair, also considering like total shoulder arthroplasties, reverse total shoulder arthroplasties. These are all cases when you have to repair the soft tissue in a way that it's a little bit delicate to start, and so you got to protect it for the first 6 weeks, and then eventually you're able to move to moderate protection and then on to return to high velocity, high load activity. So usually your first 6 weeks are in the moderate protection. Sorry, first 6 weeks maximum protection. The second 6 weeks is what's called moderate protection. This is where the physical therapy really gets fun because you have progressive loading. So let's talk about the rotator cuff as an example. Rotator cuff, let's say you have a massive rotator cuff repair. So you've got all that soft tissue that has been repaired. You want to avoid activating it during the first 6 weeks. That's why you typically don't do active external rotation, nor do you do excessive internal rotation because you don't want to activate it, nor do you want to stretch it. So you're limited there. You're doing submaximal isometrics. You're maybe getting a slight amount of activation, but you're certainly not producing a lot of force through that. You're limiting range of motion because you don't want to stretch it, and you're limiting function because obviously it's required for overhead activity, high velocity type activity. So you're quite limited during those first 6 weeks. And so what do? Well, you work on the uninvolved arm, you work on uninvolved joints surrounding it, shoulder shrugs, scapular retraction, elbow movement. So there's a lot of things you can do, but mostly you're protecting, you're keeping them in that sling 24 hours a day. You are doing gentle joint mobilization and gentle range of motion within mid-range, trying to prevent adhesive capsulitis, but really just protecting it. Second 6 weeks, you do progressive loading. We're progressing through range of motion, start to move into more active range of motion and resisted range of motion. And then finally, the return to sport is the last 6. This is where 6 months, and really we're talking about high velocity and high load. So if a patient asks you, hey, when will I be able to play basketball again? When will I be able to play soccer again? Almost categorically, the answer is 6 months. And obviously, that the big assumption there is that they will have participated in their therapy so that they are prepared to then activate or prepared to perform and participate in that activity. All right, let's see. What else do I want to say here? So Katie asks, good question. When do you introduce eccentric strengthening for tendon repairs? So eccentric strength, we know about concentric strengthening. That's when you're shortening the muscle. And eccentric is when you are having a resisted lengthening of the muscle. Most of the time, that eccentric loading is going to occur in that second 6 weeks, usually towards the end of the 6 weeks as the tissue can tolerate it. Now, remember, maybe this is, so Katie, you and me, I'm talking knee to knee with you right now. This 666 rule applies to tissue reconstructions and repairs. For the case of like a total knee arthroplasty or say someone with a lateral epicondylitis, eccentric training is done quite early to activate the muscles. But I want you to see this distinction. In those cases, you haven't reconstructed the quadriceps. Rather, you're trying to activate the quadriceps so that they can more adequately hold the patient. So Point is that this 666 rule applies to tissue reconstructions and repairs. So other things to remember, this is a fun little acronym, is salute. So the scapular upward rotators. I feel like this is such a frequent question. So it's really just understanding what muscles assist with upward rotation of the scapula. We know that to elevate the arm overhead, you have to upwardly rotate the scapula. So SALUT indicates the serratus anterior, the lower, and the upper trapezius. These are the three muscles for the upward rotation. The other one I've got here is if you love ramen, that would be the downward rotators. You got the levator, so levator, the rhomboids, and the pec minor. These all work to downwardly rotate the scapula. So you've got salute to upwardly rotate the scapula. And if you love ramen, it's downwardly rotating the scapula. And the reason that that becomes important is because on test day, they'll give you a question that says something like, the serratus anterior is disturbed, or you have difficulty with rhomboids. What activity will be most difficult? And they'll list some activities that have upward and some that have downward rotation as a component. And you say to yourself, all right, well, if it's one of the upward rotators, they'll have difficulty with upward rotation. Or where they get really tricky is they talk about the loss of an upward rotator. Then I ask what position the scapula will be in at rest. Well, if you can't upwardly rotate, then you'll be stuck in a downwardly rotated position because the upward rotators are gone. So you default back to downward rotation. So that's a classic example. There will probably be 50 questions on test day that are quizzing you about, do you know what one muscle does and what the antagonistic muscle is doing as well in that relationship? And so you'll see those come time and time again where you have to distinguish between what muscle is being activated versus what muscle is being stretched. And that's, as another example, like someone who has a tendinitis, the tendinitis is typically worsened with activation of that tendon or stretching of that tendon. So with agonistic movement or antagonistic movement, you'll see worsening of the symptoms. Excellent. So that's an example there of some of the upward and downward rotators. Here's a full list, just in case you're interested. The upward and downward rotators, you've got the serratus anterior, serratus anterior, lower trap, upper trap, and then levator, scap, rhomboids, and pec minor. These are all acting as force couples, or it's where you have all these muscles working in unison to perform a singular activity. So that's what I wanted to say there. That's an example. Like I told you, the 666 rule, saving my bacon on a bunch of questions. Just speaking of the scapula here, just another one that's a brief note. You want to make sure that if you see winging listed on the exam, it's going to be a serratus anterior loss or long thoracic nerve. This is where you have difficulty protracting the scapula, but you'll also have difficulty with upward rotation because the serratus anterior is an upward rotator. And so just keep that in mind. The serratus anterior is assisting not only its primary movement is protraction, but it also assists with that upward rotation. There's an interesting side note here that you can have what's called lateral border winging. So the classic is that medial border. That's where the medial border pops off the thorax. A lateral border winging, that's most likely due to a trapezius loss. That's not likely to show up on the exam, but I did want to at least mention that it's not just the serratus. That serratus is most likely implicated in winging, but there are also some other things to consider. All right, let's see. Just looking through, I see a bunch of questions. There's some good questions over here, so we will talk about a bunch of these as best as I can. There's a question comes across. Is there a PDF to today's session? There is indeed. I'll post it over in the chat box again. There's some question about some spinal stuff. We'll talk about that. Anyway, I see a bunch of questions. I'll get through as much of that as I can. Of the things I've also got for you here, some other little acronyms that are helpful for me. When you're doing cervical testing, one of the ones that comes up fairly frequently is the vertebral artery test. So vertebral artery test is looking for vertebrobasilar insufficiency. The little acronym you could write down is VOA. The vertebral artery test is testing the opposite artery. So VOA, vertebral opposite artery. So what does that mean? That means as you rotate and side bend and extend to the left, you are testing the right vertebral artery. So that's the relationship between the vertebral artery test and the artery it's testing, the vertebral artery that is being tested. The alar ligament test, this is a super annoying test because you're testing the alar ligaments. That's being shown in this image. They're two small ligaments that hold C2 on C1 or C1 on C2. And so the way that the nasty question is written, it'll say something like, with cervical side bending, when would you expect to see C2 move when initiating movement with C1? And the answers are 0 degrees, 2 degrees, 4 degrees, and 6 degrees. You're like, what in the world? Well, just remember the alar ligament is supposed to hold C2 and C1 tightly together for side bending. So C2 spinous process should move immediately when you side bend C1. And that, so the correct answer would have been at 0 degrees. You would have seen immediate movement with side bending. The sharp pursure test, this is another one it's related to the transverse ligament test, but the sharp pursure test is a relocation maneuver. So that's maybe why it's a little bit tricky, is that it's a test that relocates or reduces symptoms, which is opposite of the transverse ligament test. Transverse ligament test, you're pulling on it, trying to provoke symptoms, whereas the sharp pursure test is you're pushing the forehead back and relocating C1 on C2. And so if you can imagine someone is trying to kiss you, they have pursed lips, and you're pushing their head backwards. That's your sharp pursure test, rebuffing someone's pursed lips to relocate. Let's see, other items here I wanted to mention. So speaking of the transverse ligament, I feel like this is one. Help me out here in the chat box. This seems to come up with fair frequency. The transverse ligament is most likely to be lax in what conditions? So what I'm asking you is what conditions are likely to cause transverse ligamentous laxity? And so there's a bunch to choose from. So I think most of you are seeing this. So like Down syndrome, Ehlers-Danlos syndrome, pregnancy is on that list. Rheumatoid arthritis, I'm glad you mentioned that. Rheumatoid arthritis is pretty high on this list as well. I guess these are not in any particular order. Marfan syndrome also on this list. So when it's the reason this is important is because you as a therapist need to protect that transverse ligament. And so in these cases, you'll be extremely cautious. The one that I see maybe the most frequently is with Down syndrome. You try to counsel about activity modification. So what activities are recommended? What activities are recommended for someone with Down syndrome? Well, you would want to avoid what? So you're going to avoid really like gymnastics and trampoline. So a somersault. Really, it's all about axial loading. What about contact sports? Yeah, so Aubrey's with me here. Contact sports are typically ill-advised. Now, obviously, there are some varying degrees here, and I hate to say it depends. You'd have a symptom-based approach, right? But generally speaking, you'll avoid trampolining, you'll avoid somersaulting, anything where you could disrupt that transverse ligament, which is quite lax in someone with Down syndrome, that you could develop the patient could develop a spinal cord injury very quickly unless you counsel them otherwise or counsel them to avoid activities. And, frankly speaking, the caregivers, parents, they're trying to do the very best for the kid. And so you just need to help them know what would be safe activities versus unsafe activities. And that's again, a classic line of questioning on the exam. Excellent. The one that's, I don't know why, but it's still kind of an outlier to me, but rheumatoid arthritis. Just remember, rheumatoid arthritis presents with transverse ligamentous laxity. That autoimmune attack also hits the transverse ligament. And so these folks are at risk of developing those symptoms of a lax transverse ligament. So they would appear like they've got cervical myelopathy. So a constricture of the cervical spine. It'll present a little bit like a spinal cord injury as well. So again, that would be a classic line of questioning that could be followed on exam day. All right, talking now about just kind of the last little thing on MSK I wanted to mention, because this will also show up about 25 times on the exam, is if you understand the difference between active insufficiency and passive insufficiency. So an example of active insufficiency that could show up on a test question would be, in order to get the best grip strength, you'll find that it's best if your wrist is extended about 30 degrees. And so that'll be the question. Like when lifting a heavy suitcase from the floor, what position is the wrist in? Well, the wrist is going to move into slight extension so that you get a a good length tension relationship on the long finger flexors, because all of you, and some of you have done this with me already, but go ahead and do it again. Put your wrist into full flexion and now try to make a power fist, and you'll find that your muscles, the flexors, just can't contract anymore. You're contracting as best you can. You get a better relationship when you move the wrist into extension. You get a much more powerful fist. And so that's an example of active insufficiency. Now, passive insufficiency, this is the inability of a two joint muscle to stretch across both joints fully. And I think we all agree that maybe the most classic one is the hamstring stretch. That as you are stretching a person's hamstring, you would expect that if you flexed the knee, that you'd be able to move into more hip flexion, because the hamstrings, what's the function of the hamstrings? The hamstrings are hip extensors, are they not? But they have to be stretched to move into hip flexion. And that's another example of agonist versus antagonist that could show up on exam. So then the follow-up question I have to you is with that, can passive insufficiency ever be helpful? Can passive insufficiency ever be helpful? And the short answer is yes. And there are three main cases you could make for it with spinal cord injury. The three main cases are: one, the tenodesis grasp. If you keep the finger flexors very tight, then as you extend the wrist, you can passively flex the hand, or flex the fingers. That would be in the case of a C6 spinal cord injury, when you can extend the wrist and it passively closes the hand. The other two are both related to upright sitting for someone with a spinal cord injury, that you want to have tight quadratus lumborum. You want to have a tight QL. And why is that? Well, it's to hold the posture upright. The other thing you want is about 100 degrees of hamstring length. So 100 degrees of hamstring. Why is that? Well, it's so you can maintain your center of mass on your base of support without flopping down, without folding totally in half. So a question comes across, what about for spinal cord injury, the tenodesis grasp? Yes, so the tenodesis grasp, it is a passive insufficiency that is helpful for the patient rather than, I guess everyone experiences passive and active insufficiency to any number of degrees, but a tenodesis grasp, that's essentially passive insufficiency of the finger flexors, so that as you extend the wrist, you passively flex the hand. See, Dayton is asking a question that I know the question you're asking, and I'm actually blanking on the answer. The question Dayton is asking about when you are creating a power grasp or power fist, and the question, Dayton, there's actually two parts to this question. The question is basically, number one, when you create a power fist, which way does your wrist deviate? Does it deviate to the ulnar side or to the radial side? So I'll ask you that question. If you're making a nice power fist, so everyone make a nice power fist for me, which way do you deviate? Either ulnar or radial deviation. Which way do you deviate? And the answer is ulnarly. So we typically deviate ulnarly. But, Dayton's question, I think you're referring to the suitcase question, lifting a heavy suitcase from the floor. So when you grasp or hold that heavy suitcase from the floor, you extend the wrist and radially deviate because you're lifting the suitcase up off the floor. That's your target, is to lift up off the floor. So Dayton is kind of a two-pronged question. If you're just making a power fist, you're moving into slight ulnar deviation. But if you're lifting something heavy from the floor, you tend to lift it off the floor with a little bit of radial deviation as well. So tell me if that jives with what you saw, but I want to say that's the one. Maybe you're referencing something totally different, but that's one that I saw that was kind of a pain. They were lifting off the floor and it required radial deviation because it was a function. They were functionally lifting something off the floor. All right. Just a note here. I wanted to make sure that I said this at least 3 times, and I did it in the VIP class a couple times, and I want to make sure I say this again, that pulse grading, the normal pulse grading is 2 plus, despite what some of the other resources have. It's so funny to me how much disparity there is between different resources. But the one that I want you to remember is 2 plus is normal on your grading pulse grading scale. So I didn't want to just drive by that. I'm talking about neuro. There was a question that came across about neuro. Let me see if I can cue it up here real quick. Peripheral nerve injury versus a nerve root. So that's huge on the list. They're going to ask probably at least 5 questions that'll be relevant to your peripheral nerves versus your terminal branches. So we'll talk about that for sure. Starting with the cranial nerves, it surprises me. There's really usually not that many questions on cranial nerves. There's something will be mentioned about it, probably show up on a couple of questions, but it's not in a huge amount of detail. So with that in mind, you need to know them, but you don't need to spend forever on the cranial nerves. So the way I learned it in PT school was on old Olympus towering top, a finely vested German viewed a hawk. So that's just the acronym for your cranial nerves. Another one that a student had was, oh, once one takes the anatomy final, very good vacations are heavenly. Whatever it is you use, I would recommend that you have the saying in your head, and rather than write down the whole saying on your brain dump, write down the acronyms, or sorry, the first letters, so it is an acronym, but write down OOOTTAFVGVSH. And by so doing, you'll find that you can very quickly reference your cranial nerves. And then the secondary part is the sensory, motor, both. So what is it? Some say marry money, but my brother says bad blood, marry money. There are less G-rated versions of that, but in any case, you can try to memorize some things so you can remember what's sensory and what is motor. Let's see. Danielle says, "Oh, on they traveled and found Voldemort guarding very ancient Horcruxes." I like that. I very much like that. One of the reasons that one of the ways they'll make you do problem solving with these cranial nerves would be, as an example, the pupillary light reflex, the same thing with the gag reflex, and the same thing with the corneal reflex. These all follow the same pattern that you have to differentiate between a sensory branch and a motor branch. So if we were looking at the eyeballs, we're looking at our eyes, the pupillary light reflex is where you introduce light into one eye, but you see a consensual response in both eyes. So you see constriction, pupil constriction in both eyes, pupil constriction in both eyes. So then the question is, all right, what would happen if you observed, so as an example, let's say that you introduced light into the right eye, but you saw only a left response. So what do yeah, and that's what I've written here. If you introduce stimulus into the right eye and observe a response in the left pupil only, what's the problem there? If you introduce light into the right eye and observe a response in the left pupil only, what's going on? Well, right cranial nerve 3 is not working. That's the motor output. So cranial nerve 3 is involved in pupillary constriction, and cranial nerve 2, optic nerve, is where you detect it. So in this case, if you introduce light to the right eye and had a response in the left pupil only, it would be the right cranial nerve 3 that would be the problem. And then the final question is, if you introduce light stimulus to the right eye and there's no response, then what's the problem? If you introduce light into the right eye and there's no response, well, chances are that it's more likely to be a cranial nerve 2 issue, where the right cranial nerve 2 did not detect the stimulus, and so therefore there was no response. So I guess the problem solving we'll do on test day will be mostly around, do you understand the sensory branch and the motor branch of these reflexes? And it's, like I said, it's the same thing for the corneal reflex, where you touch one eye and you get both eyes closing. And the same thing with the gag reflex, where you touch the uvula, and you should see a contraction of both sides. Again, that's the sensory and motor branches uh, for all these. All right, just a note of terminology here. Sometimes you see this term strabismus. Don't be thrown off if you see strabismus. Strabismus just means that your eye is stuck either laterally or medially. So lateral strabismus, stuck laterally, that's what would cause that. Well, loss of medial structures would cause you to deviate laterally because if it's unopposed, you get the eye shooting out sideways. So loss of cranial nerve 3 would lead to a lateral strabismus, whereas a medial strabismus would be loss of the lateral rectus, the cranial nerve number 6. So those are examples of cranial nerves problem solving that you could have on the test. Abigail says cranial nerve 3, loss of cranial nerve 3 also presents with ptosis. So ptosis, the drooping of the eyelid. And so cranial nerve 3 is involved in lifting or opening the eyes. Cranial nerve 3 is the eye opener. So loss of cranial nerve 3 means your eyes won't open very well. So that's a good point too. I've mentioned this in class as well, but the cranial nerves, this fun little acronym CMI pons medu, helps you remember the locations of each of the cranial nerves. So the first two, CE, the second two, MI, there are 4 letters in PONS, so 5, 6, 7, 8. And finally, MEDU, the last 4 letters are 9, 10, 11, 12. So it's just a way of remembering the origins of the cranial nerves. So now I wanted to dive in. We're going to, let's see, kind of a neuro. I need to rearrange. I don't know how my shoulder, well, I know how I did it. The spinal and shoulder stuff. I guess let's just go through that real quick. Then I do want to talk about peripheral nerves versus nerve roots. So let's talk about that here in a moment. First, I just wanted to define our terms, the spondees, all the different spondees. This is one that could be very confusing on test day, so I wanted you to remember. You've got spondylosis. This is where you have a degeneration of the discs, and so you tend to get narrowing of the intervertebral foramen. So essentially, this is degenerative disc disease. Ankylosing spondylitis, so there's lots of spondies. So we got spondylosis. Ankylosing spondylitis, so that's bamboo spine, usually in middle-aged or young adult males. It can occur in females too, but young adult males with stiffness lasting more than an hour. Spondylolysis, so we got spondylosis, spondylitis, spondylolysis. When you see lysis, remember lysis means a breakage. So spondylolysis is that Scotty dog fracture with some slight anterior slipping as you've lost one pars intra-articularis. And then finally, spondylolisthesis is where you have true anterior translation, a bilateral fracture, and that spine is now unstable and moving forward. So there's 4 spondies here: spondylosis, spondylitis, spondylolysis, and spondylolisthesis. So practice saying that 10 times. Kalia says, is the spondylolysis, is that best observed with an oblique view x-ray? Yes, it is. So the oblique view x-ray is how you visualize that, and that'll show up on it. I've seen that on with relative frequency on questions. There was a question that came across with, who was it that asked this question? Let's see. The question came across about, so Kali is saying spinal mobilizations in the spinal mobilization. So let's talk about that for a moment. When it comes to side bending and rotation coupling patterns, I have listed here the side bending rotation coupling patterns. Now, I want to focus on the most likely to be tested, and I'll make brief mention of what possibly could be tested, but I'm going to focus most of my time on what is likely to be tested. So the most likely to be tested is mid-cervical spine and mid-thoracic spine. This is where the side bending and rotation occur in the same direction. So when you side bend right, the vertebral bodies rotate right. Side bend, rotate right. For the lumbar spine, the thing you have to remember is that it's opposite. So side bending and rotation occur in the opposite direction. When you side bend left, the bodies are rotating right. So those are the different coupling patterns for the spine. And I'll give you some examples here in just a sec of how to apply this on a test question. There's a couple of questions that come across. What is the best view for spondylolisthesis? So we talked about the oblique view for spondylolysis. Spondylolisthesis, I'll ask you that question. How would you best view an anterior slippage of the spinal cord? And you'd say to yourself, well, it's got to be a lateral view. The one I see on questions, though, is that oblique view. The spondylitis, ankylosing spondylitis, that's most likely observed really with every x-ray, but that would be an anterior view, AP view. And then stenosis, yeah, really it's going to be an AP and lateral view. I guess I've never seen a question about spinal stenosis and which view is best. Question comes across, do we sit or stand? I think almost all these are done in weight bearing. I'm not aware of one where it's done in sitting. Someone will correct me on that if you've seen one in sitting, but almost always the x-rays are done either in weight bearing or supine. I think the ones they most likely do are the standing ones. All right, let's talk through a couple of examples of these spinal coupling patterns. So I'll describe it once, and then we'll see if we can answer any questions about it. So let's first of all put our vertebral bodies with a posterior view. Some of you have seen me draw my boxes before. And the reason I like these boxes, it helps to just makes everything just so clear. When you consider the facet joints on both sides, you got these zygapophyseal facet joints on both sides. You got the transverse processes on each side, right? So this is our posterior view, transverse processes, and we see the zygapophyseal facet joints. We're going to put this right in the middle of the cervical spine, C5, C6, and C7. Now, if we were to rotate to the right, so we're going to do side bending and rotation to the right, what happens? Well, because it's cervical spine, the side bending and rotation occur in the same direction, meaning that as you side bend right, you rotate right, and you get a closing or approximation, I'll just put closing, on the ipsilateral side, and an opening or a gapping that occurs on the contralateral side. And why is that? Well, it's because I drew my little pictures so box-like and linear, but really these are in the 45-degree plane, so that as you side bend and rotate the right, you're kind of having this up glide and down glide occurring on each side. And so in a real sense, as you side bend and rotate to the right, you are down gliding ipsilaterally and up gliding contralaterally. And that's just what's happening to the vertebral body. So we got up gliding and down gliding, which causes a closing or approximation on the ipsilateral side and an opening or a gapping on the contralateral side. So now to apply this in a clinical case, if a person is having difficulty with a right rotation, you will assist them by doing up gliding or down gliding, depending on which side you're pushing on. You will up glide on the contralateral transverse process and down glide on the ipsilateral transverse process. All right, give me a thumbs up or a thumbs down on that. How do you feel about that? Give me a thumbs up or thumbs down on that. Excellent. So just to repeat one more time, when you are assisting with side bending and rotation, you have to assist the movement of the vertebra. So in order to do so, you will assist with up gliding on the contralateral side or down gliding on the ipsilateral side. And that's what I tried to draw here. Now, I don't want to muddy the waters too much. That's the simplest explanation. There's a lot of nuance here, but I'll muddy the waters a tiny bit by saying, all right, well, Will, that's great. We talked about C5, C6. Okay, we open the contralateral side and we close the ipsilateral side. Okay, fine. What if they don't give me those options? What if they give me a different option? Well, my question to you is, how can you also close that ipsilateral side? Well, you can up glide on the inferior segment or down glide on the inferior segment to create a relative closing or opening on those facet joints. So I'll say that again. if you look at, if our target is moving C5 to the right, our side bending rotation to the right, so we want a C5 on C6, side bend and rotate to the right. If that's our plan, well, you can side bend and rotate the C5, or you could twist C6 the opposite direction to create that relative closing on the ipsilateral side and opening on the contralateral side. Because again, I don't know, it's like if you're going to clap your hands, you could bring one hand over one way, or you could bring the other hand over the other way, and you'll still achieve the same goal. That's probably not a very good analogy there. But the point is that the ultimate goal is to open and close those facet joints. And so how do you best do that? Well, you either approximate on the ipsilateral side, or you gap or open on the contralateral side. Good. And the question comes across about translation or lateral translation testing. And so I'm going to point this out. I'll draw a quick image and then I'll describe it a little bit more here. So let's say, so this is not side bending and rotation. Now we've kind of, in fact, I should put it on a different slide deck. Stand by. Another slide. All right. So now we're going to do translation or lateral gliding. So I want you to look at, we're going to stack up the vertebral bodies again. We got C5, C6, C7. This is again a posterior view. And this is another thing you'll do on test day with your brain dump is you can draw these things out. And so that's why, again, I try to make a simple schematic so you can draw it out on test day. So I want to ask you, if we were to apply a side translation force, a side glide, translation, so lateral translation, I want you to look at a lateral translation that we place on C6. So if this force is translated into C6, we're pushing on C6, what is the result of that? Well, if those of you think of it, it's not purely like a Jenga tower or a Lego tower. Rather, it's like an elastic band tower that, assuming that you've stabilized the head, what happens is you have pushed sideways on the spine and distended it laterally. Would you agree with me there? We have distended it laterally. By so doing, what have we done to the facet joints? So what have we done to the facet joints? Well, we see that on the contralateral side, so if this is our posterior view, this would be the right side, but we've opened the contralateral side and we've closed the ipsilateral side because essentially we've created a side bend. And so we're still applying the same rule. Just in this case, we've put a lateral translation force. Excellent. Just a lateral translation force is creating it's like if I pushed in the middle of my hand and it would make it appear like a lateral side bending. All right, so there was a follow-up question that said, in the lumbar spine, they said, hey, Will, just so you know, on the lumbar spine, the slide deck, it says the opposite and the same. If you look down here, say, Will, what's going on? Like, did something break in your brain when you put the opposite and the same on the same slide for the lumbar spine? Now, the reason it's there is because it exists. There's a lot of nuance here because if you do rotation first versus side flexion first, there is some difference here. They're not going to test you on that on test day. They're going to test you on general vertebral motion with general side bending or rotation motion. So that's why I don't want to dive too deep here because the test is tomorrow. And again, I want to avoid cramming. But the one you've got to remember is the opposite. That if you side bend to the right, it means you'll have rotation to the left. And that's the simplest way to put it. Understanding that there is, and like I say, side flexion first, you get there's actually, just of note, there's actually quite a bit of research and disparity in the research about what's exactly going on with what movement occurring first. So again, that's why As far as what you need to know for the test, the lumbar spine, it's opposite. It's opposite. All right. Other things here. So a follow-up question says, to achieve extension, how do you best achieve extension? Well, to achieve extension, you need to, so in order to achieve, this again, this is a posterior view, you need to close bilaterally. So for what's called mass extension, you need to close bilaterally. So how do you close bilaterally? Well, you've got two options. You can down glide. So we're going to down glide on the superior segment, or you can up glide on the inferior segment in order to create that mass extension. So your follow-up question says, sorry, my internet got cut out. Example for cervical side bending and rotation. Would there be side bending right and rotation right and closing on the right? Yes, that is precisely. Such a good summary. Side bend right, rotate right, closing right for the cervical and thoracic spine. Excellent. All right. Other things to talk about here. I just want to mention very briefly the shoulder when it comes to mobilization, that it follows your arthrokinematic convex rule. So you have for an external rotation, do an anterior glide, an internal rotation, you do a posterior glide. Like that was the question I saw once. It showed a patient doing the back scratch test where they're lifting their hand and scratching. You can't see my hand behind me, but lift your hand up on your back and scratch as far as you can. And the question was basically what mobilization would best help? Well, it's internal rotation. So what best helps with internal rotation? It's going to be a posterior glide. The only major exception here is for adhesive capsulitis, and it's only for adhesive capsulitis. You just do a posterior glide. Posterior and inferior glides are the best for adhesive capsulitis. Regardless of what you're trying to do, just do a posterior glide. That's only for adhesive capsulitis frozen shoulder. Everything else follows a similar pattern. So now we get to the fun question that was asked here. How do you differentiate between peripheral nerve and nerve root? So on the list is you look at the symptoms. I mean, I know that's so simplistic. Like, Will, of course you look at the symptoms, but as an example, let's see, do I even have the nerve roots? I don't even think I included the nerve roots. Yeah, I didn't even include the nerve roots on this. But let's all do this as an example. So I'm going to ask you a question here. So this is my question. How do you distinguish between a C7 nerve root and a radial nerve injury? So that's my question. How do you distinguish between a C7 nerve root and a radial nerve injury? And you'll give me my own answer back. Well, Will, you look at the symptoms, right? Let's talk about this precise symptom. So for C7, we know that its myotome is what? The myotome for C7 is what? So those of you who've been in my classes, you know I like the basketball free throw shot as a way to remember your myotomes. So C4 is you shrug your shoulders. Everyone do it with me. C4, shrugging the shoulders. C5, you come to ready position, abduction and flexion. Abduction of the shoulders, flexion of the elbow. Then you come to C6, which is elbow flexion, wrist extension. C7 is elbow extension, wrist flexion. You make the shot. So you take the shot, you make the shot. That's C8. And then T1 is you peace out of the gym. You're on your way out. That's T1. So myotome for C7 is elbow extension and wrist flexion, right? So, okay. The dermatome, where is the dermatome test for C7? Where is the key test point? So tip of middle finger. Okay, so tip of the middle finger is your target dermatome test for C7. All right, so now let's look at the radial nerve. Motor function of the radial nerve is what? I think someone's already mentioned it, but elbow extension and wrist extension. So we've already found a difference here that you're going to look at the function of the wrist, the motor at the wrist, and then sensory. Where is the sensation input from the radial nerve? It gets sensory input on the dorsum of hand and forearm. So we found something else that's different. So if a person, so on test day, if they say, all right, a person has weak elbow extension, what's the problem? They're like, well, need more information. All right, so weak elbow extension and they have weak wrist flexion. Like, okay, that's starting to sound a lot more like a C7 than a radial nerve. And then the final thing is they say, and they lack sensation at the tip of their middle finger. They're like, okay, that's totally C7, not the radial nerve. All right, let's see. So whoever asked that question, tell me, does that jive with what you, does that help at all? Talking about nerve roots versus terminal branches. The most common one I think is C7. We could also do an example of, well, I don't know. If you had another example you wanted to do, we could do it. But otherwise, is that helpful to you? The other thing I just remember, everyone hold up your hand. C6 is on the thumb. C7 is on the middle finger, and C8 is on the little finger. So you're just going to go C6, C7, C8, C6, C7, C8. And if you know the thumb is C6, then that helps you with your key test point for C6. Excellent. Very excellent. All right. Just mentioning here a couple of the terminal branches. Some of you have heard my fun acronyms here. I guess I'm biased. I like my acronyms. Any of you who have cool acronyms too, please feel free to chime them in. Very, very, very excited to hear other acronyms as well. The radial nerve is a beast. Abductor pollicis longus, brachioradialis, extensor anconeus supinator triceps. And that's what's listed here. Just the one little note here. Sometimes you get questions about the PIN or the AIN. The AIN versus the PIN. The PIN is a loss of wrist extensors, but there's no sensory loss. It's a branch of radial, and it really just hits the wrist extensors. Whereas the AIN is a branch of median, and it does the tip-to-tip pinch testing. So that AOK test sign, it's a branch of median. The median is the half loaf of pumpernickel. 1-2 lumbricals, then that's the 1-2L. Opponens pollicis, abductor pollicis brevis, flexors on the radial side, and then both pronators. And again, that's what's listed here. And then finally, the ulnar nerve is the mafia. So medial 2 lumbricals, that's the M. Adductor pollicis, that's one you've got to remember. You must remember this one. Flexors on the ulnar side, interossei, and the abductor digiti quinti. Good. All right, let's see. Irene says, what is the radial nerve, or why is the radial nerve wrist extension again? So the radial nerve innervates all of the wrist extensors. So extensor carpi ulnaris, extensor carpi radialis, every extensor, extensor digitorum, every extensor, anything that starts with extensor is the radial nerve. Danielle says, wait, can you repeat the PIN and the AIN thing again? My brain glitched. Yeah. So the posterior interosseous nerve, the PIN, posterior interosseous nerve, it's a branch of radial, comes through the arcade of Frosch, arcade of Frosch under the supinator, and there's getting everything mixed up again. Yeah, the supinator, arcade of Frosch, supinator, comes through and it hits just wrist extensors. So extensor carpi radialis brevis, extensor carpi radialis longus, extensor carpi ulnaris. Yeah, all the wrist extensors are hit by the PIN, the PIN, posterior interosseous nerve. It is almost pure motor with no sensory loss. So if there's sensory loss, then it can't be just the PIN. It could be the entire radial nerve. The AIN is a motor branch of median nerve that hits the flexor digitorum profundus and flexor pollicis longus for that tip to tip pinch. So Danielle, how does that sound? Is that, speaking of thumbs up, excellent. The question that came up the other day, I thought this was great, is let's say that you had an ulnar. So I mentioned the ulnar nerve only very briefly, adductor pollicis, flexors on the ulnar side. So the question came up was about Guillaume's canal. So what if you had, um, it didn't even go into that. The question said something like this. They had um, compression at the hamate bone. What symptoms are most likely to show up? So very formal language here. Compression of the hamate bone, but what symptoms are most likely to show up? Well, this is Guillaume's canal of the ulnar nerve. And so you would expect loss of ulnar muscles with primarily, we're talking about the interossei, so intrinsics of the hand, as well as adductor. Did I spell it right? Interossei, as well as the adductor pollicis. Excellent. So that would be an example of compression at the hamate bone. The ulnar nerve crosses between the pisiform and hamate in what's called Guillaume's canal, and it hits all the intrinsics on the ulnar side of the hand, including adductor pollicis. Excellent. Very good. All right. So other things I want to mention, lower extremity. I don't have as good of acronyms here. So you're all, please feel free to chime in with any fabulous acronyms you've got. The femoral nerve hits the F-quips. So femoral nerve hits the quadriceps, iliacus, pectineus, sartorius, and saphenous. Remember, saphenous is a sensory branch. Sensory. The deep peroneal nerve, it's a branch of the common peroneal, so a branch of common peroneal, and it hits all of your tibialis anterior and extensors. So obviously you have a lot of foot drop issues if you have deep peroneal. Superficial peroneal hits all your peronei, peroneus longus brevis, and it's also a branch of the common peroneal. And then finally, tibial is the gas plant, gastroc soleus plantaris, tibialis posterior, and then the flexor digitorum longus, flexor hallucis longus. All right. Linda asks, are there any special important differential diagnoses here? Yes. A critical one you've got to know is the difference between the saphenous nerve and the sural. I don't have it here. I got to put this on the list. And the sural nerve. So the saphenous nerve is a sensory branch of the femoral nerve and hits the medial malleolus, whereas the sural nerve is a branch of the tibial nerve and it's on the lateral malleolus, lateral side. So the way I remember this is there's an L in sural. So if you remember there's an L in sural, then you know it's on the lateral side. So as an example, let's say that a person had sensory deficits on the medial malleolus. Is sural nerve a possibility? And the answer is no. Tibial and sural are not possible because they innervate the lateral side. This is the plantar surface of the foot and the lateral malleolus. The sural and saphenous nerves are both sensory branches only. Saphenous and sural are both sensory only. Let's see, Irene says the femoral nerve could have the mnemonic SIS equals PQ. So you've got the sartorius, saphenous, iliacus, and then PQ for pectineus and quadriceps. Love it. Love it. Excellent. All right, just hit on a couple of claws here as we come closer to the end. So we got we got the median claw and the ulnar claw. The median claw is when you attempt to make a fist. So everyone's making a lot of fists today. Hopefully not shaking your fist at me, but make a nice fist. And if the first three digits don't move, then that means it's a median nerve issue, a median nerve that hits those first three digits. However, if the hand is at rest and the fourth and fifth are stuck in a lumbrical flexed position, then that's an indication of an ulnar lesion. So on test day, they'll say something like, when attempting to make a fist, the first three don't move. Like, all right, that's a median claw. Or when the hand is at rest, the fourth and fifth are stuck in a flexed position. All right, that's the ulnar nerve lesion. So we got the median nerve and ulnar nerve. Dupuytren's contracture, this is an actual aponeurosis tightness. Think of it like a joint contracture. So it's not a nerve issue. Rather, it's an induration. It's a joint contracture of that palmar fascia. So you have these contracted nodes that prevent fourth and fifth from extending. So that's Dupuytren's contracture. And finally, we get to the palsy. We've got Erb's palsy, which is the waiter's tip deformity, so loss of the upper brachial plexus, and Klumpke's palsy, which is the lower brachial plexus. And my silly way to remember that is Erb's palsy is first in the alphabet. So Erb's and Klumpke's, so E versus K. E is at the first of the alphabet, so it hits the upper brachial plexus. And then Klumpke's palsy gets the lower brachial plexus and is a clawing loss of the intrinsics of the hand, basically loss of C8 and T1. Excellent. Meta says, can you get Dupuytren's contracture in any fingers, or is it always just those two? I believe it's usually those two. But I'm not. The disease process that causes the Dupuytren's contracture could hit. I mean, frankly, could hit a lot of the fascias. You could get it in the fifth, the fourth, and the third. So there's certainly, I think there's some variability there. Some variability there. All right. So what other questions? What other questions do you have about that? So we got our, our palsies. Let's see, what else did I want to say here? Let's check my notes. All right. So what else? Let's talk now. There's a question that came across about the pectineus muscles. So now I'm double checking myself here. Pectineus, let's see. Gets from the femoral and the obturator nerve. So that's what it is. So Kaliu said I thought the pectineus was innervated by obturator. I believe it's innervated by both. So that's why I've seen it on the femoral nerve list, but like I said, just double checked here. But it also fits. What is it? I think it's split. Like you can actually get some bilateral innervation or sometimes femoral, sometimes obturator. Someone can double check me there. All right. So a couple other things I wanted to mention here. Just want to show the referred pain patterns. So a bunch of referred pain patterns could show up on the test. Most likely one you'll see would be like the liver and gallbladder in that right shoulder. So you have right shoulder pain. It's likely to be liver and gallbladder. Left shoulder pain, we're talking about the heart. The stomach is in the epigastric region. So stomach, you can also get mid-thorax here. So stomach is also on that list. Kidney, everyone knows McBurney's point. The kidneys you can get the flank pain. This is called flank pain. The costovertebral angle, so you can get that costovertebral angle. Kidneys you can also get on the anterior side as well. So flank pain on the anterior side with the kidneys. It's on the list. Gallbladder and liver on the right side. So yeah, that's all pretty straightforward. All right, let's talk about math on the exam. So math on the exam, an example of math on the test would be like Carvonen's method. Carvonen's method is looking at the heart rate reserve. Heart rate reserve is simply the resting heart rate compared to the maximum heart rate. Think of it like the highest your heart can go and the lowest your heart can go normally. So clearly we're not going to zero with your heart, right? You're going to your resting heart rate. That's what's called the heart rate reserve. And then you calculate your workload based on a percentage of the heart rate reserve. So your target heart rate reserve, usually it's in the 40 to 85% range. And so simply you calculate the reserve and then add it back to your heart rate at rest. Your heart rate at rest plus your whatever heart rate reserve you want, that gives you your target heart rate. So So that's an example of math that could come up on the test. So as an example, let's say we had a 60-year-old individuals. So they're 60 years old, which means their age predicted heart rate max is going to be 220 minus age. And there's some controversy like, okay, is that a very accurate estimate? Well, it is just an estimate. It's a back of the, it's a scratch pad estimate. And so it's helpful to get close to the ballpark. So 220 minus 60 gives you 160 as our age predicted heart rate maximum for a 60-year-old. And as we'll just give you, they'd have to give you the data here. So the resting heart rate, we're just going to say is 60. That's on the list just for easy math. And so therefore our heart rate reserve is what? Well, it's your maximum minus your minimum. And you can see easy math here would be 100 beats per minute. All right, that's the heart rate reserve. So now we calculate we'll just pick a number here, just an arbitrary number of that heart rate reserve. Let's say we did, I don't know, let's do 60%. 60% of heart rate reserve is 0.6 times 100. You can see why I chose this easy math. On test day, it'll be very similar to this as well. 0.6 is supposed to be 6 times 100 gives us a heart rate reserve of 60 beats per minute. So then the final step is to take your heart rate at rest plus your target heart rate reserve, so percentage heart rate reserve, which is 60 plus 60. They both end up being 60 in this made-up example for 120 beats per minute as your target aerobic exercise heart rate. Very good. So that's math on the test. Similarly, the ankle brachial index is another example of math where you're taking the ankle blood pressure as it compares to the brachial or arm blood pressure. So you take the ankle blood pressure divided by the systolic blood pressure for a ratio or an index. And so this is one where you have to take, I don't know, we'll make up some numbers here. Let's say that our ankle blood pressure, systolic blood pressure is 100 millimeters of mercury. I'm just making up these numbers here. And let's say the arm or brachial blood pressure is 120 millimeters of mercury. So in this case, you have to take 100 divided by 120. And so 120, it can't go into 100, so you have to add, do you remember doing this in elementary school? You add a 0, so it goes in there 8 times. So 8 times 12, we got 960. Gives you 40 left over, doesn't go into the 4, so you have to add another 0 on there. It goes in there, 3 times? 360 with a leftover of 40. And so you can see this is going to be 0.83333 repeating. And so that's where on test day, you'd say, all right, 0.83 is going to get me awfully close to whatever and to compare that against the answers they give you for the ankle brachial index. So now I've got a tough math question for you. I'm going to queue up a poll box for you. I'm going to give you a moment. Here we go. So just kind of a generic poll box will jump up in front of you. If you don't mind, take a moment, respond to this question, and then we'll talk about it together. All right, just another moment. So those of you on a mobile device, you might have to scroll between the screens to be able to see the question and then the poll box. All right, so this question is an annoying question because it's asking you about the duty cycle. So a patient is receiving NMES with an on-off ratio of 1 to 4. So what is the duty cycle? Well, the definition of duty cycle is the on time divided by the on plus off time or the total time. So that's the total time. Meaning, how long does it take for a complete cycle to occur? Well, a complete cycle only occurs after you've had 1 second on and 4 seconds off. So therefore, it's 1 divided by 1 plus 4, which is the same as 1 divided by 5. So therefore, the correct answer is that 20% duty cycle, 1 divided by 1 plus 4. This is different than the on-off ratio. I guess that's the distinction I'm trying to draw in your mind. On-off ratio, simply on time to off time. The duty cycle is on time to total time. And I hate for you to miss that question on the exam. Hate for that. It'd be a pain. All right, so that's other math on the test. Let's see, we talked about that. Other numbers to remember on the test. Here's some ADA requirements. Some numbers you've got to memorize here. The one that's the hardest to work through. So you got the hallway 36, doorway 32. I mean, that's all pretty straightforward. Carpet pile, it means how fluffy the carpet is. So how fuzzy the carpet is. So you can't have shag carpet. It's got to be very, very thin, flat carpet. The ramp slope, this is the one where I see come up as far as calculations go on the test. It's a 1 to 12 ratio, meaning for every, it's rise over run, meaning for every 1 inch up, you have to go 1 foot sideways. And those of you who are not accustomed to American measurements, you'll say to yourself, well, why in the world? Well, this was made back in the 90s. So what is it? George H.W. Bush, I think, signed it into law. Maybe it was late 80s. So it's been around for quite a while. In any case, the 1 to 12 ratio is 1 inch up to 12 inches of run. So that's where you get the 1 to 12 ratio, which is the same thing as an 8.3% grade. 8.3% grade. So how do you calculate it? Well, if you know what your rise is, then you can calculate how much of a run is required to have the appropriate slope. So if your rise is, I don't know, let's say 20 inches, then you know that it would have to be 12 times longer, so that 1 to 12 ratio. So if it's a 20-inch rise, then that would mean, what would be a 240-inch run, which is the same as 20 feet. I get that right? 2 times 12 plus a 0, 240, yeah. 240 inches or 20 feet. Very good. All right. So let's see. All right. I want to talk now. I'm going to do rapid fire here in a moment. Because there's a few questions queued up for rapid fire. I'll do as many as I can. We're already kind of over time a little bit, but I wanted to talk briefly about your test day experience. Just some things to remember. Don't forget your ID. Got to bring 2 forms of ID. Just follow that authorization to test letter as quickly and not as quickly, as best as you can. You follow that ATT letter for what ID requirements they want you to bring, usually a photo ID plus a non-photo ID, or you can bring 2 photo IDs, just basically 2 forms of identification. You plan your day. Make sure to smile for your photo. They won't let you cheese it. I've had people who try to like cheese it and have a goofy smile. They want you to have a normal face, but at least have a power pose, look at it, have a gentle smolder going on in your face, at least a pleasant look on your face. Keep good posture. There's a lot of evidence to support that posture has a strong correlation with your mood and attitude. Average about 1 hour per section or less if you can. Mini mental breaks. So this is so critical. As you fatigue during the test and develop test fatigue and test boredom, you have to self-evaluate. So a lot of self-analysis going on. And really you're asking yourself the question, am I 100% focused at the moment? If you are, great. If you're not 100% focused, how can you refocus yourself? Well, you've got to pause for a moment, rest your eyes, re-engage. It's a recentering strategy. The goal being to bring your mind back to what you're doing right at that moment. And you'll find that's very helpful, especially as you fatigue in the final sections of the exam. Start with positive attitude, can-do attitude. There is a correct answer and you can find it. I want you to have my voice. I don't know, maybe that'd be too stressful to have my voice there, but at least have that thought. There is a correct answer and you can find it. There is a correct answer, and you can find it. And then finally, just look for the most plausible answer. They're going to put some tricky ones in there, but remember that there is a correct one and you can find it. So there was a question that came across, or I thought your comment was brilliant. I forgot to mention it, but the test centers are classically very cold. So you need to wear layers, especially if you are prone to being cold, just because they have to keep the AC cranked up for all those computers to function properly. So it'll be quite cool in the room. So bring a couple extra layers if you can. They'll check. You want to make sure to check your pockets. I had a student who accidentally left her iPhone in her hoodie. She was wearing a hoodie and she left her iPhone in her hoodie pocket and forgot to take it out. And rather than just leave it alone and leave it there, she, after a while, she's like, I used the timer on it when I was practicing. And so she pulls out her iPhone. She's like using the timer feature on it. And the proctor saw her and stopped the test and said, hey, cheating going on here. And so I was shocked when she was only barred from taking the test for 2 years. And so she had a 2 year suspension on her test. So don't do that. Leave your phone and everything in the locker. They provide it for you. Just leave it all there. Check your pockets, check your sleeves. Just take yourself in and yeah, get to work. Oh my goodness, there was something else critical I was going to tell you. It'll come to me here in a moment. But yeah, we already talked about hydration, talked about leaving your cell phone in your locker. Yeah, make sure to. Oh, I know what it was. So one of you asked the question is, I'm trying to remember what it was exactly, but the question was, is the exam in October the same as the exam in July? And the answer is no. Let's see. The question comes across, could there be any similarity between July and October exam? The similarity will be in the topics. So they'll test you from classically tested topics like the MSK system, neurocardio, cardiac rehab, the nerve roots, peripheral nerves, like all that. That will be tested. But the specific questions are extremely unlikely to show up again. They only use each question about one time before they throw it away forever. Wouldn't that be great to get that test bank with all the throwaway questions from the exam? So the questions will be developed the same, have the same core material, same source material, but they will be different questions. And all of that's an attempt to prevent cheating. Question comes across, is the exam in October harder than the one in July? And the answer is no. That's the reason they use a scaled score, is to account for small disparities in exam difficulty. Because actually, when you take the test tomorrow, there's no way of you knowing this, or it won't even really matter. But on test day, there are somewhere between 5 and 10 forms of the test, meaning that if you're sitting next to a friend taking the NPT, they'll take a totally different form of the test. So it's not just a singular test, it's about 5 different forms of it. And so to equilibrate those, they use a scale score. And so that's why you have to achieve a 600. Another myth that I feel like has been making the rounds lately is, is each question equivalent to every other question in weighting? And the answer is yes, that each question doesn't matter. Like what I heard from a student was, is it true that if you miss all the safety questions, you'll be failed? And the answer is no. Every question is equivalent to every other question. You just answer every one and you'll be fine. Just answer every question, you'll be fine. Katie says, is there a raw score that you get at the end of the test? Unfortunately, no, you just get the crippling anxiety for a week. I like, Danielle, that's brilliant how you said that. Yes, you must wait 5 business days until your score is given to you. And the reason they do that is because of like test center disruptions or weather events where, someone can't test on Wednesday, they have to wait till Friday and sort of a thing. So that's why they leave the time frame. Justin asks a question, do they give hard questions for those who appeared already once, and for fresh test takers, it is easy? That is not the case. The exam forms are preset, so you just get, it's like a cafeteria lunch. Like they have pre-packaged this test, and they just sling it at you and say good luck. No test is harder or easier. Certainly not dependent on who it is. It's blinded to whoever. There's no bias for who has tested, who has not tested. They just take that cafeteria lunch, they give it to you, and they say good luck. Linda says, are all the test results released on the same day for both Tuesday and Wednesday test takers? Yes. So it'll be, if I'm not mistaken, it'll be Monday night of the following week, you'll get the test results. So test Tuesday, Wednesday. Following Monday night, they have to have everything all set by Monday, and then you'll get your test results. All right, so now we get to rapid fire here. We're going to go rapid fire here. These are going to be extremely brief responses to your questions. I'm going to do my best. There's just too many. I won't be able to get to all of them, but I do want to get to some rapid fires here. All right, so I know there's a question about temporomandibular joint, temporomandibular joint, TMJ. IMOP. Well, that's one acronym. That's for lateral deviation. IMOP is for deviation, lateral deviation, for lateral deviation. Meaning that you have ipsilateral masseter temporalis with opposite pterygoids. Also for TMJ, you have to close your mouth. That's the medial pterygoid. And if you say la, 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 open mouth, then that's the lateral pterygoid. The other thing is for opening, you use the lateral pterygoid, as we talked about. Pterygoid, and it involves anterior glide of the mandibular condyle. There you go. That is the opening for TMJ, lateral pterygoid, anterior gliding of the mandibular condyle. Excellent. All right, next question. So that's, again, really quick description of the temporomandibular joint. Because let's see, Heather asks a question, can you talk about the types of temporomandibular joint dysfunction and what you've seen regarding to displacement without displacement? So the simplest way to put it, again, rapid fire, if it's stuck closed, so if the jaw is stuck closed, then what does that mean? Well, that means that you have a anteriorly displaced disc. The disc is stuck in front of the mandibular condyle. And if it's stuck open, then that's a posteriorly displaced disc. All right. Let's see. Grace asks, great question. This question is about the mnemonic devices for the straight leg raise test. So straight leg raise, also called Lessegu's test. I think that's what I might have misspelled that name. Lessegu's test. But this is where you have your classic straight leg raise test. This is where TED, SID, and PIP come into play. Where if you want to bias the tibial nerve, you'll do eversion dorsiflexion. If you want to bias the sural nerve, we already talked about sural, right? It's a branch of tibial. You'll do inversion dorsiflexion. And finally, for the common peroneal nerve, you'll do inversion plantar flexion. Excellent. So that's your TED, SID, and PIP. We already talked about spinal pathologies a little bit. So, I know. Someone asked a while ago what the difference between, and I'm going to apologize, I won't be able to get to everyone's question, but it was a great question. The question was about spinal versus, oh my goodness. The question is about claudication. So you've got two main types. You've got spinal claudication, and it's spinal claudication versus vascular Claudication. So spinal claudication, this is when you have symptoms in the calf associated with spinal position. So, for instance, this is where someone with a spinal stenosis, it's with um, worsened with extension. So these folks have a flexion bias, meaning it feels better with flexion, or with a herniated disc that's worsened with flexion, and so they have an extension bias, meaning that it feels better with extension. Whereas vascular claudication, this is where you have symptoms are increased with activity, with cardiovascular vascular load, and decreased with rest, not dependent on spinal position. So that's the biases. Let's see. So Tatum asked that question. Excellent. Already talked about some of these. Let's see. Some test navigation questions. Question comes across. I know we can't bring coffee in the test room with us, but can we bring coffee and leave it in our locker to have on our breaks? I believe you can. You can bring all your snacks and phone and everything. Just stick that all in the locker. Yeah, you can't take it to the desk with you. And Jessen pointing out that spinal claudication is also neurogenic. It's neurological in nature. Another follow-up question is, are you able to highlight throughout the question along with crossing out options? Yes, you can highlight text of the question. You can also cross out options. You can mark the items. They have no bearing on your score. They're just helpful in navigating the test. Excellent. All right, let's see. We talked about the intermittent versus, oh yeah, vascular claudication is also known as intermittent claudication, vascular claudication. Let's see. Question comes across. Oh, there's lots of questions. Let's see. I want to make sure I'm answering all the questions I can here. Let's finish up with. Well, Grace asked a question: are there any specific advice for a retest taker? It's tough when you're testing again after a failed attempt. It's super disheartening to walk into that test center again and to be worried about failing again. It's obviously a high stakes exam, and with that experience fresh in your mind of failing it, it's a pain. It's a royal pain. So as far as the advice goes, you try to go back to control what you can. Anxiety and distraction are much mitigated if you focus in on what you can control. And so, as best you can, you control your self focus. You control what you're doing at that moment. You control your thought process. You control your pace. As much as you can, you control your environment. And by so doing, it tends to improve your positive mental attitude as you're driving through the test. Now, obviously, it's not just oh yeah, I'll have a great attitude. Like, why not? Rather, it's kind of a circuitous path, kind of jumps up and down. You just have to remind yourself, all right, I'm good at this. I can find the answer. I'm good at this. I can find the answer. And you'll have to do that more as someone who's taken the test a second or a third time. You'll find yourself doing that a lot more to stay positive, and you'll find the thoughts creeping in. You got to kick back out to positive attitude. It's tricky. It's really tricky. Linda points out you have more experience from your previous. So obviously, you have experience with the test, so use that to your advantage. Like, you know what this test is going to be. You don't have to worry about some things. Like, you don't have to worry about what the test is going to look like. You don't have to worry about when the break is. You know your pacing. A lot of things you do know. Excellent. All right, so I think we'll bring it to a conclusion there. I know there's a lot there's just so much we could talk about. I know we're way over time, 90 minutes in. I hope this has been helpful to you as we've gone through all this content. I know that that it's a pain coming through this test, but the biggest thing I want to say to you is thank you. Thank you for the effort you're putting into becoming an awesome therapist. Thank you for your efforts in studying for this test. Thank you for spending the time with me. I know that it's a sacrifice of your time on the day before the test to come and spend with me. My hope is that this was helpful to talk through some last minute things, at least prompt your memory on some things to say, all right, this is what I need to know for the test. This is what I could put on my brain dump. But I guess just give yourself a big pat on the back. Let you know that I care about and hope that you have a fabulous test experience. I hope you'll let me know how it goes. It has been so great to have you, especially those of you who've been a part of our classes up until now. It's fun to get to know you, fun to be a part of your experience and journey. So thank you. Thank you for what you do. And if you want to do me a solid today, those of you who weren't or who aren't in our classes, or any of you who are in the classes, do me a big solid. Go leave us just a quick review on the NPTE podcast. It only takes 1 second, and that would be a great favor to me if you wanted to. So anyway, Danielle says, I can't believe I got to match the Will Crane's podcast voice with his face. Well, just wait till you come and visit me at like a CSM or something. You'll stop by and you'll see me. And most people tell me that I'm taller in person because on a screen, I'm just about 2 inches tall. Most people tell me I'm taller in person. But in any case, thank you so much for your effort and you being a part of your journey. Please let me know how it goes after your exam. I'm super excited to hear about that. Message me with any questions. I'll do my best to get to as many as I can. In the meantime, Will Crane fist pumps all around. Remember, you're good at this. This is something that you are so good at. It's an intersection of your skill and your interest. Give yourself a little fist pump when you do it right. I'll catch you all after the exam, if not before, and have a fabulous day and good luck on the test. I'll be so anxious to hear. Have a great day, everyone. I'll talk to you soon.